All right, I'm going to start. So, good afternoon, everybody. I'm talking about itch and pain. Mainly, I'm going to talk about itch, because that's more interesting for this talk. In terms of financial disclosures, I have spoken for Walgreens Infusion Services, but there should be no conflict. My objectives for the talk today is I'm going to talk about a case of itch and talk about central itch and anatomical localization of itch and pain, as well as the interaction between itch and pain, peripheral pathways of itch, and disorders of neuropathic itching. So let's start out with, it's a pretty famous case, and it's really illustrative of what can happen with itching. So it's a 39-year-old woman who developed typical shingles in her right forehead. Past medical history is significant for symptomatic hepatitis C and HIV infections. She had previous drug abuse controlled by methadone. She had personality disorder and depression, but no history of obsessive compulsive disorder and no other neurologic complaints or diagnoses. So she was treated with acyclovir. The shingles lesion resolved, but itch without pain ensued. She started to scratch her right forehead with her fingernails. This is what her head CT looked like. So she scratched through her scalp and bone and caused a subdural collection of fluid. The scratching was painless.
Did she have pain? I mean, in the
She did not have pain.
So she had lost pain.
Right. And this is what it looks like when she scratched it through. It's a pretty famous case. So they put a graph on top of it. Then she scratched through that. And she had wound cultures of the dura, the epidural fluid, and subdural fluid. And it showed Staph aureus and strep. The skull fragment also showed osteomyelitis. So the scalp was, she had to have it translocated over the skull to close it. So what was she treated with? She was treated with phenytoin, nortriptyline, SSRIs, gabapentin, diphenhydramine, and that did not help. She used intranasal lidocaine gel, lidoderm patches applied over the right forehead, the lidocaine block above the right eye. That only gave temporary relief. So how does severe itch coexist with profound damage to cutaneous sensation, to profound damage of cutaneous sensation innervation? And that's, I think, a similar problem to what I see a lot in my clinic in terms of neuropathic pain. And the people who described this case talked about three possibilities to explain that. One was something that we talk about a lot, central sensitization. So central itch neurons are firing excessively when deprived of afferent input, so phantom itch phenomenon. And this is possible even though modulating peripheral sensory neurons by scratching a local anesthetics was helpful. So because she got the lidocaine and lidocaine block and the lidoderm patch, that should decrease the input to sensory neurons. However, she was still having itching, so that's why it could be a central phenomenon. Another way to explain what she's experiencing is preservation of a few scattered sensory neurons after shingles may have allowed for activation of occasional second-order neurons without concomitant recruitment of inhibitory neurons. So this is the interplay between the activation neurons and the inhibitory neurons. So you had lots of those sensory neurons in the skin, but that may create an electrophysiologic situation similar to when fully innervated skin is stimulated by minute punctate stimulus. Another potential explanation that they came up with was the few remaining cutaneous neurons may have itch fibers from adjacent unaffected dermatomes, and these dermatomes tend to be really large, up to 8.5 to 10 centimeter diameters, and that extend beyond the traditional dermatomes, and those were exciting. So there is a medical definition of itch, and it's the following. It's an unpleasant sensation producing a desire to scratch. And this was described by a German physician in 1660. So why do we itch? What's the point of having itching? So the teleological reason for itching is really probably to make us pay attention to what's going on. pain elicits a withdrawal response, and that's kind of more of a reflex. But itching draws attention to a particular area of the skin and elicits scratching, potentially to remove insects. There has been an epidemic of itching going around in the world, and I want to talk about that. Worldwide, there's 3 million people that suffer from itching, from scabies, biting mites. In the U.S., itching is reported as a symptom by patients in more than 7 million outpatient visits per year. 32 million Americans suffer from itchy, inflamed skin and eczema. 42% of nearly 19,000 kidney dialysis patients surveyed in 12 countries suffer from moderate to severe itching. Now, itching has a lot of etiologies, and there are a lot of different reasons why you can have itching. And there's been a conference about how you classify clinical itching, and they classify it into mainly 5 categories. So, the first category is itching caused by skin disorders, and those are mainly inflammatory dermatoses, including atopic dermatitis, psoriasis, drug reactions, mites, and urticaria, as well as dry skin, which you hear a lot about in the wintertime. Those are thought to be mediated by histamines, interleukins, prostaglandins, and proteases. The therapy for that are usually antihistamines, anti-inflammatory medications, immunomodulatory topical and systemic therapies such as cyclosporin, pimecrolimus, tacrolimus, and corticosteroids. A lot of these inflammatory dermatoses, such as atopic dermatitis, actually don't respond to antihistamines. So there's probably a different reason for that, and maybe we'll talk about it a bit. Itching caused by systemic diseases are usually what we've talked about already in terms of the chronic liver failure and a chronic renal failure. A lot of these seem to be mediated by opiates, interleukins. Part of that is because naltrexone, these opiate antagonists, as well as the kappa opioid receptor agonist, seem to be helpful, as well as gabapentin. There are definitely studies that show that gabapentin is helpful for chronic liver disease and chronic renal failure-induced itching. The category that we're going to talk about mainly is neuropathic itch, and that can occur in post-herpetic pruritus, notalgia, paresthetica, brachioradial pruritus, and I guess post-stroke itching, which I haven't really seen. But the first 3, we'll talk about more in detail. This is thought to be damage to nerve fibers and release of neuropeptides such as substance P and proteases. And medications we use are gabapentin, pregabalin, and capsaicin. There's also people who have psychogenic itch. Those stem from delusions of parasitosis, stress, and depression. And for those, I don't know why, I don't think they're mediated by serotonin or norepinephrine in the skin, but that's just the central process. These you treat them with medications for the psychogenic component. And there's a component of overlapping and mixed itching. Let's talk a little bit more about central itch, because that's a subset of what's happening. Central itching can occur from lesions to the central nervous system. Multiple sclerosis has been reported to have itching, brain tumors, stroke, brain abscesses, and brainstem gliomas. And brainstem gliomas, that quite a few patients have been reported to have itching. Here's one case that was described, and this is I believe a 9-year-old boy who had itching really just on the right side of his face, around his eyes and his forehead. And he went to his primary care physician and got treated with steroid cream and got better, but then it came back. And so they finally did more and more studies and found out there was a brainstem glioma on the right side. Now, how does this cause itching? How does a brainstem glioma or a multiple sclerosis lesion cause itching? And those are really not known, but how do we localize itching? Let's go back to the localization, as we're neurologists. So the next part I want to really talk about is anatomical localization of itch and pain, and an interaction between itching and pain. pain. And so I'm going to start from the skin and go all the way up to the brain in terms of the localization. So here are the nerve fibers that innervate the skin. Here's the epidermis and dermis. And the main thing I wanted to talk about are the pain fibers are these free ending nerve fibers that basically penetrate through the dermis and just have free nerve endings around the epidermis dermal junction. And that's really where our signals start for pain as well as itching. And next, this slide is really talking about, once again, different types of sensory nerve fibers that we have. And we have the A alpha, the A beta, A delta, and C sensory nerve fibers. And the things that we're really going to focus on with pain are these A delta and C fibers. These fibers vary in diameter size from 1 to 5 microns to less than 1 microns, and that is reflected in the speed by which they conduct, which is 3 to 30 meters per second for the A delta and less than 2 for the C fibers. All these different types of fibers mediate different types of modalities. The A alpha does muscle spindles, the A beta do touch, pressure, and vibration, and the A delta and A beta are what really are the nerve fibers that mediate pain. The A delta, which conduct a little bit faster, if you recall, are fibers that really mediate more of a sharp pain. The C fibers, which conduct really slower and have a larger area of innervation, conduct burning pain, temperature, as well as itching. So let's go back further from the skin, and these are nerves. Where do they go? So this is the skin, and you have these itch fibers, which are red, and these blue fibers, which are pain. They go through the dorsal root ganglion, and they end up on the lamina 1 of the spinal cord. And then they cross over pretty fast, and they ascend through the spinal thalamic fibers. So
are you saying itch fibers are different from the pain fibers?
I think I'm trying to build up that story, yes. Okay. Let me try to convince you of that.
Yeah.
I have to talk about something for a whole hour. So these two different types of fibers are the C fibers, and they innervate. They basically contact neurons in lamina 1 of the spinal cord. And these fibers then cross over and they ascend the spinal thalamic tract. They go around the periaqueductal gray area and then go to the thalamus, the ventral medial thalamus, the posterior part of that. And then they go and innervate different parts of the cortex. So these are spinal and supraspinal pathways of pain as well as itching. So once you get up to the brain, it enters the thalamus, and then it goes, the fibers spread throughout. A lot of times it goes to the somato sensory cortex to help with localization, and then there's a direct connection to the motor area that causes you to itch. Some of these fibers go to the insula and the anterior cingulate cortex, and that gives you feeds into a affective aspect and aversiveness, and gives you a sense of suffering. And you can also have some innervation of the frontal cortex, and that gives you a sense of pleasure from itching as well as reward. So this is where you trace the pathway of itching from really the skin to the brain. And so for the patient who had the Brinson glioma, the question is maybe the hypothesis was maybe it's affecting the periaqueductal gray area, and that's what caused the itching. This patient did not have any pain. So what kind of interactions are there between itching and pain? And Dr. Swanson's question is, are they different pathways or are they similar pathways? Is itch just a very slow kind of pain? And so the next section, I really want to talk about the interaction between itch and pain. So once you get to the brain, the areas activated by itch and pain are very similar. The anterior cingulate, the insular cortex, the premotor and supplementary motor areas, the cerebellum, primary somatosensory cortex, and thalamus. These are all very similar areas. Pain can inhibit itching. The itch sensation can be reduced by the painful sensation caused by scratching. Painful electrical stimulation reduces histamine-induced itching for several hours at a distance up to 10 centimeters from the stimulated site, suggesting a really central mode of action. Chronic itch is suppressed inside the secondary zone of capsaicin-induced mechanical hyperalgesia. Analgesia may also enhance pruritus, and this is something that is quite well described in the literature of epidurally administered opioids. So spinal administered mu opioid receptor agonists can induce segmental analgesia, but they induce segmental pruritus. If you use a mu opioid receptor antagonist, that has antipruritic effects. That's been shown in experimental itch studies as well as patients with cholestatic itch disease. Kappa opioids do something counter to what mu opioids do. Kappa opioids antagonists enhance itch in animals, and kappa opioid receptor agonists have antipruritic effects in animals, and they're antipruritic in patients with cholestatic itch. Buprenorphine, which is a substance that has both mu opioid antagonistic and kappa opioid agonistic effects, they've been found to be effective in the treatment of chronic intractable itching. So the question really remains, is itching really different than pain? Because we see there's a huge interaction between the two. So a lot of this really was explained in understanding the molecular mechanism of itch, which is what I'm going to go through in the next section. And this is really what's really fascinating, and a lot of that has been done really in the last 10, 20 years, and I think that's really, really fascinating and fun. So the molecular mediators of itch, the main ones that I want to talk about are histamine, cowhage, and chloroquine. There are definitely a lot of other mediators of itch. Cannabinoids can cause itch. NGF can cause itch. A lot of different mediators can cause itch, but these are the ones in which the pain receptors have been really worked out. Histamine is something that we all commonly know. It causes the wheel and causes a large area of neurogenetically mediated vasodilation termed flare, and that's thought to be mediated by an axon reflex. There are also non-histaminergic itch, and these could be caused by mechanically induced itch, which is probably what happens when a ant just crawls on top of you. But you can also have itch that's produced by these two compounds, cowhage and chloroquine. These types of itching are different than the histamine-induced itch because they don't have any wheel or axon reflex flare or erythema. So let's talk a little bit more about histamine. Histamine is the best known pruritogen. Histamine-induced itch causes a wheel and axon reflex flare in the human skin, and that's almost completely suppressed by inhibitors of the H1 receptors, although local erythema still remains. However, the clinical use of H1 inhibitors are only successful in few pruritic diseases. It does not treat all urticaria, and it's ineffective in many other diseases such as atopic dermatitis, leading to people to think that there are non-histaminergic causes of itching and atopic dermatitis. A little bit more about histamine receptors. There are 4 G-protein coupled receptors, and I think that's a theme to the talk on the molecular mechanism of itching. All of these are mediated by G-protein coupled receptors. HR1 and HR4, histamine receptor 1 and histamine receptor 4, are the major and minor itch receptors, respectively. Let's talk about cowhage. So this is from the plant cowhage. It's a tropical plant, and it produces these spicules, and that comes from these pods. And these spicules cause itching when they insert superficially into human skin. And a lot of these studies are done when they insert these spicules into human skin and record their neuronal and activity. The active puritogen is this molecule called the mucinin cysteine protease, and once again, doesn't cause any wheal flare or redness. So these cysteine protease activate these receptors called protease activated receptors. The protease activated receptors is 4 different subtypes. They are also G protein coupled receptors, and they're really interesting. They are activated when you cleave off the N-terminus, and it generates a tethered ligand that then activates the receptor itself. So it's a really interesting way of activating it by protease, by these proteases. PAR2 and PAR4 mediate itching. PAR2 is activated by mast cell tryptase, trypsin, and cowhage. And cowhage, as you guys remember, is a protease. And people think that it's this mast cell tryptase, these mast cell tryptases that are activated in atopic dermatitis that causes this sense of itching, and that these itching are results of the activation of these protease-activated receptors. PAR4 can be activated by trypsin, thrombin, and cowhage. I don't know how you would be exposed to trypsin and thrombin, but that seems to be one way that you can activate these receptors. Chloroquine is an anti-malaria medication, and that has a side effect of itching, and it's thought to activate this G protein receptor protein, and it's one of these mast-related G protein receptors, and for chloroquine is the A3. So how does this work? In these C polymodal terminals, we'll go into that in a little bit. What happens is you activate the PAR2 receptors, you cleave them off, and they fold back onto themselves as they're tethered and activate the receptors. That, in conjunction with protein lipase C, activates the TRPV1 receptors, as well as this other receptor called TRPA1. This causes inhibition of the potassium channel, and this activates the signal for these cowhage and these PAR2-mediated itching. If you have histamine that's causing itching on the sensory termini, you activate the histamine receptors 1 and 4. It also activates the protein lipase C beta 3 activity. In conjunction with activation of TRPV1, it causes an increase in calcium, and that causes the release of these calcitonin related proteins, and that activates those receptors. So these are once again, these are free nerve termini, and the epidermal dermal junction. Cowhage activates it, and as well, or histamine activates it when it's released from mast cells, and this activates these 2 different types of nerve fibers, and it goes into the spinal cord, activates them, and sends on up the pathway that we talked about.
These are both C-type fibers.
These are both C-type fibers. Yeah. I'm going to go into that in a little bit more detail. There's a lot. Let's just move on from that right now. So the TRPV1 receptors are these receptors that seem to unify all types of pain function, and they seem to be more and more important in a lot of things that we're looking at in diseases of nerve and muscle. They respond to eicosanoids, which are prostaglandins, histamine, bradykinin, ATP, and various neurotrophins. All of these have endovenoid functions. They activate or they sensitize these non-selective calcium-permeable TRPV1 receptors. Other puritogenic stimuli, such as mild heat, if it's greater than 43 degrees Celsius, and acidosis, can directly or indirectly activate or sensitize these receptors. Topical capsaicin, which also interacts with these receptors. They suppress histamine-induced itching. So let's talk a little bit more about the C fibers. So let's talk a little bit more about the proprioceptive primary afferents. These are unmyelinated C fibers, and there's mainly 2 types. There's a mechanoresponsive polymodal nociceptors, as well as a mechano-insensitive silent nociceptor. So the difference is in terms of how they respond if you put a von Frey filament on top. If they are responsive to those, they are called mechanoresponsive polymodal nociceptors. And if they don't respond to the von Frey filaments, they're the mechanoinsensitive silent nociceptors. So there are two different types. And what the big news is in the 1990s was when they found out a specific type of unmyelinated C fibers specific for itching. So they found that the histamine-sensitive C fibers respond in parallel to itch sensation are the mechanoinsensitive C fibers. And they found them in healthy volunteers and in patients with itching. So what they did was they took somebody's leg, they put on a little device that did infuse histamine, and then they recorded from the superficial peroneal nerve and tried to record activity. And so in the top thing here is in the gray bars when they infuse the histamine, and then they look at it over time, over 14 minutes, and they're recording from the superficial peroneal nerve, and recording the activation of those nerve fibers. And they're looking at discharge frequency. It starts out about 30 seconds after the infusion, and they start to activate the nerve fibers, and they get discharged. Now, when you ask the patient, what are you feeling? Do you feel an increase in itching? You can see on the panel here, C, is that over time, they get a sense of itching, and it decreases over time. And this sense of itching it occurs around the same time as you are activating the nerve fibers that mediate itching. And these are single fibers that they are recording from, suggesting that there are specific fibers that respond to histamine, and that response causes an actual sensation of itching. So this is suggestive that there's definitely nerve fibers that really just mediate itching. Now, when they looked at this in the cat, and they looked at the spinal cord, they looked at the projection neurons and recorded from them. After about 2 minutes, after infusion of histamine, these nerve fibers in the spinal cord started firing, and they started tapering off over the next 10 to 14 minutes. Now, these are the mechanoinsensitive fibers. These are the ones that don't respond when you put pressure on them, these von Frey filaments. What about the C fibers that respond to von Frey filaments? So they're mechanosensitive. So they also recorded for those. Those are the polymodal primary afferents, the polymodal C fibers. And what happens when you activate your little device that infuses histamine? You do have discharge frequencies, but it doesn't last for long. It doesn't cause it to continue to have discharge after the infusion of histamine. And for these patients, they really don't experience itching. They experience pain, and it's really at the time when you apply the pressure of the device. That's what they're responding to. There's an increase in pain. Now, if you do that to a cat and you record from their spinal cord, these neurons are basically firing most of the time. That's why you can see there's a baseline firing. When you infuse the histamine, right after, you see some firing of those neurons, but it's a really short amount of time. So this suggests that there are specific fibers that histamine activates, and they don't usually activate these types of polymodal C fibers. So one of the two. But these polymodal C fibers are activated by another puritogen, and that's cowhage. So none of the mechanoinsensitive C fibers afferent responded to cowhage. And those are the ones, if you recall, are the ones that respond to histamine. Now, when they recorded about 38 of these mechano-heat-sensitive fibers, 84% of them responded to cowhage. And a majority, right, so, but in monkeys, histamine also activated them. So they respond both to histamine and cowhage. But the histamine ones don't really respond to cowhage. The histamine and cowhage responsive neurons are also found in spinal projection neurons in the monkey. John.
So a couple slides back, I just want to make sure I'm understanding. When you're measuring the projection neurons in a cat,
Yeah.
for the silent C fibers, are we postulating that that has some sort of sensory inhibitory effect? Because when those fire, that's when the sensation is going down. Or is that just some kind of a delayed response?
Yeah, I don't think people know because you can't really ask the cat. But I think what happens, this sensation here is actually mediated by the thalamus and the cortex. That sensation.
This isn't some inhibitory interneuron somewhere. This is the directly connected projection.
Right.
Okay.
Directly connect projection to the C fibers in the spinal cord, the lamina 1. Alright, so these spinal projection neurons, they also found that they were very specific itch neurons. So recording from the dorsal horn neurons in the cat, these histamine neurons, histamine-sensitive neurons, only represent a small fraction, about 5% of the spinal thalamic projections. The mechanically insensitive, the ones that respond to histamine, these are mechanically insensitive and respond to histamine as a typical prolonged activation. And those don't exhibit the spontaneous activity. So to understand this better, we need to go to the mice and look at knockout mice. So there are definitely mice that don't itch as much, so let's talk about them. There's a genetic basis for an independent itch pathway, and this was in 2007. It was first looked at when they looked at a DNA microarray searching for itch-related genes in the spinal cord of mice, and they found this protein called the gastrin release peptide receptor, GRPR, expressed at high levels in spinal neuron stalk to convey itch. The mammalian homologue of it is the amphibian bombasin-like peptide receptor. So when they look at the DRG neurons, this is looking at the dorsal root ganglia, they found that the GRP, the gastrin-related peptide, and the TRPV1 co-stain these DRG neurons. So here in red are these DRG neurons, they stain for red the gastrin-related peptide, and these are the same neurons that also express the TRPV1, the capsaicin receptors. When you double stain, you can look at yellow. A lot of them, right? You see only the ones that are GRP positive are also TRPV1 positive. Now, these GRP fibers and these GRP receptors are restricted to the lamina 1 of the spinal cord. So this is the mouse spinal cord, and this is lamina 1. Red is the GRP, the gastrin-related peptide, and it's really only in the lamina 1. The IB4 is a marker of pain fibers, and they're in lamina 2, and so they really don't intermix. So there's really just specific subset of neurons in lamina 1 that express GRP. If you look at the receptors, looking at their expression by in situ hybridization, you can see that the receptors for GRP are only expressed in lamina 1. So, knowing that GRP is important, they then knocked out GRPR, the gastrin-related peptide receptor, and they looked at those spinal cords. So here are the spinal cords. Once again, here's lamina 1. This is the CGRP, the calcitonin-related peptide, and they are expressed both in lamina 1 in the mutant mice as well as the wild-type mice. Substance P, which mediates pain fibers and pain sensation, are also in lamina 1. So there's really no change in those molecular markers for pain. IB4, which is really marks lamina 2, are really not affected, and here's another one, PKC gamma. For these mice that have GRPR knocked out, the question is how do they respond to pain and itching? So what they found was there was no change to pain. Doing a couple of tests, one is a paw withdrawal latency. I believe that's when you pinch them and see how long it takes to withdraw their paws. These mutant mice took just about 12 to 15 seconds to withdraw their paws. Now, if you put them on a hot plate and you increase the temperature and see if they withdraw their paws to pain, the latency at 48 degrees Celsius, 52 and 56 are no different between the wild-type mice and the mutant mice. And then you have one in which you just start slowly applying more and more force to their paws and see at what point do they start yelping and wanting to bite you. It was same in the wild type and GRPR mice. So these mice had no difference in how they reacted to pain, not experienced pain. Scratching was different. So what they did was they did intradermal injection of the compound 4880, which is a histamine releaser from mast cells, as well as a PAR2 agonist called, I'm not going to pronounce that, and also chloroquine. So the black dots are the mutant mice, and the wild type mice are the open circles. We're looking at the number of scratches per minute, and this is looking over time on the x-axis. So you can see for, let's say, for the wild-type mice, over time, if you inject into their skin this compound 4880, you can see that they start to scratch probably up to 50 to 60 scratches per second, and it starts decreasing over time. If you knock out the receptor, there's a decrease. It's not as great in histamine, but definitely more in the PAR2 agonists, and the chloroquine, there's definitely a decrement in how much you're scratching, suggesting that these mice, they don't really require, it's probably not necessary, but it's a big contribution to how they respond to pain is the GRPR. So what if we try to look at mice that were normal, but we do a different experiment and we actually inject an antagonist to the GRPR receptor. So that's what they did in another set of experiments. They did intrathecal injections of GRPR antagonists, and that significantly inhibited itching. Once again, we're looking at the compound 4880, which does mediates histamine, and PAR2 as well as chloroquine. And when you infuse in GRPR antagonists, it decreases the number of scratches in 30 minutes. It's significantly decreased in PAR2 when you infuse PAR2 or chloroquine. But if you use this GRPR and you look at histamine or formalin, we'll see it on the next slide, there's really no effect. So this is formalin, this is the wild-type mice and the mutant mice, and there's no change in how much they scratch, as well as the histamine. Maybe there's some decrease, but it wasn't really significant. So what do these studies tell us? It tells us that GRPR is an itch-specific gene in the spinal cord. You can't really extrapolate that the GRPR neurons are itch-specific because they can express more than one gene, more than one GRPR gene. So there are other sensory modality-specific genes. So in terms of, are they necessary? We don't know, but they could. They'll probably play a significant role. And so they hypothesized that selective ablation of a subset of these itch signaling neurons should not alter pain behaviors, but should affect itching. So this has been reproduced in a monkey model, and it's a different model. It's actually kind of interesting. So a subgroup of adult female cynomolgus macaque, Macaca fascicularis, a subset of these monkeys, they suffer from an idiopathic chronic itch condition. And they had this assay that was able to observe their scratching behavior twice a week for 10 minutes for 4 years. And they were able to determine if these were these were monkeys that were mild or moderate scratchers or severe scratchers. And after about a couple of years, they went and sacrificed them and looked at their skin as well as their spinal cord. So what they found there was an increase of GRP positive nerves in the skin. So here are mild to moderate scratchers, and here are the more severely affected chronic itch monkeys. And this is looking at their lichenified skin. You can see that there's a significant increase in the GRP positive nerve fibers in the severe monkeys. If you look at the spinal cord, there's also an increase of GRP positive nerves in the spinal cord. QR is just an example of the lamina 1 here, and you can see from looking at the mild, moderate, severely affected monkeys, looking at expression of GRPR, you can see that there's an increase in them. But you also can see there seems to be an increase in lamina 2 as well. I don't know how you would interpret that. Now, if you quantify them, the percentage of GRP positive nerve fibers in the spinal cord are increased. For the mild to moderate monkeys, it's about less than 50% are GRP positive. If you're severely affected, then you have about 80 to 90% of them are GRP positive, suggesting that it might be a secondary response, but it seems as though GRP is important in the mediation of itching. So hopefully in this section, I'm talking more about like just animal models of itching, and hopefully I can convince you that there's definitely pathways for itching. And these start out at the nerve terminals, that those nerve terminals are different and they encode different receptors, and they're different spinal projection neurons that are also itch responsive. In terms of the overlap between these itch responsive nerve fibers and spinal cord nerves, it's those are really hard things to really distinguish. But I think the question that people always had was itching just a really slow, was itching encoded by activating pain fibers but just at a slower speed, or are there separate fibers that just mediate itch response? And I think that a lot of the studies point to that there are two different lines of nerve fibers. One is for itching, they might have some pain sensation, but then there's ones that are really mainly for pain and that they're separate. So in the next section, I want to just go into more of disorders of neuropathic itching. And there's just a couple, and we'll just finish up there. The first one is post-herpetic neuralgia, which is kind of what the patient that I first presented had. In a study among 153 patients with prior shingles, 48% reported itching. They were more frequently on the face and head and can experience itch and pain simultaneous in the same dermatomal distribution. The treatment for this kind of itching is gabapentin, pregabalin, as well as topical anesthetics, emla cream, lidocaine patch, and capsaicin. There's this condition called brachioradial pruritus, and it's a localized neuropathic pruritus of the dorsal lateral aspect of the arm. It can also involve the shoulders and neck. It's aggravated in many cases during sun exposure, and it potentially results from a compression of the cervical nerve root in level of C5 to C8, rarely associated with spinal tumor. And there's this thing called the ice pack sign, in which they get better with the ice pack. It's often refractory to treatment, and some of the treatments are topical capsaicin, gabapentin, pregabalin, carbamazepine, lamotrigine, and surgical approaches for tumors. And of course, Mayo would describe their experience. They describe 111 patients between 1999 and 2011 in a dermatology clinic, and 80 of those patients were female, and that's pretty typical for this disease. The mean age of onset is 59, so middle age. The range is 12 to 84. It's usually bilateral. It's bilateral in their set of patients, about 3/4. 46% of them reported worsening in the summer. 22 out of 22 had the ice pack sign, so that seems to be fairly specific. 42 out of 45 patients had cervical spine abnormalities, and those are listed there. Unfortunately, 13 out of 16 EMGs were normal, so it wasn't really that helpful. But as we talked about, a lot of these are probably mediated by the small nerve fibers. They had 75 patients had follow-up. 22 of them had complete resolution or improvements. 4% were unchanged, and the rest, I think they showed up in Mayo, and they really didn't talk about the brachioradial pruritus, so it's not clear what happened. Most commonly prescribed treatments are capsaicin, triamcinolone, primacaine. Primacaine was hydrocortisone, doxepin, amitriptyline was ketamine, and antihistamines. A third of the patients had complete resolution. That had complete resolution were treated with amitriptyline and ketamine, but that's really only probably 9 patients. Other single medications that were associated with complete resolution or improvement were capsaicin, doxepin, gabapentin, triamcinolone, and carbamazepine. There was another condition called notalgia paresthetica, and somewhere I read that they think that the back scratcher was invented for Nostalgia parasitica, but I think that's just really somebody made that up. This is caused by sensory nerve entrapment syndrome involving the posterior rami of the T2 to T6 nerve roots and associated mainly with degenerative changes in the vertebrae. And they present as unilateral itching in the mid to upper back in the distribution of the T2 to T6 dermatomes. It occasionally is accompanied by burning pain, paresthesias, or hyperesthesias, and there's a lot of times a well-circumscribed hyperpigmented patch. The treatments are capsaicin, gabapentin, emla cream, paravertebral local anesthetic block, cervical epidural steroid injection, phenytoin. Other things are PT, neck traction, cervical manipulations. There are just two more conditions that I was going to talk about that are
Leo,
associated.
can I ask a question about this? How do they know that it's this entrapment? Because none of these treatments are a direct surgical attack at what would be the primary pathophysiology.
Right. I think this is all really described clinically, and a lot of these patients did have some sort of entrapment. Going back, I forgot to talk about the brachioradial pruritus. We talked about how a lot of these, 42 out of 45, had some cervical spine abnormalities, but a lot of them were really not that significant, and most of them didn't go through surgeries because they only had itching and no real weakness or myelopathic changes. So it's not really clear what the association between cervical spine abnormalities and this brachioradial pruritus. But of course, this was a paper done by dermatologists. I bet you if a neurologist was writing the paper, they would say, well, 42 out of 45, you really should see a neurologist. Let me just finish up real fast. There's two more conditions. There's a chiralgia paresthetica, which is itching in the radial aspects of the lower arm caused by entrapment of the radial nerve. And there's this trigeminal atrophic syndrome, which is localized itch and pain resulting from damage to the trigeminal nerve. It causes numbness, burning, crawling sensations. There's physical signs include excoriation, facial alterations. The nasal ala is usually involved, but the cheek, temple, and frontal scalp can also be affected. And I guess 75% of these cases improve after surgical ablation of the gastric ganglion. You can treat them with carbamazepine, gabapentin, and pregabalin. So, just in summary, I really was hoping to make the case that itch and pain appear to have independent pathways, but they modify each other, itch and pain do, and that's probably more of a central process. And fundamentally, we're all using the same medications for the treatment of itch and pain. So the treatment of neuropathic itch and neuropathic pain are similar. I have a couple of patients that had itching. One of them I treated was gabapentin, and I thought she had a small fiber neuropathy, and she got better. Another patient, I think she had more of a idiopathic eosinophilia, and I tried carbamazepine, which didn't really help, gabapentin, which didn't help. This was when I first came to University of Washington, so I wrote on a prescription for marijuana. Turns out you don't do it that way, but she never tried it, so I don't know if that helped.
I've got some bad itching.
But yeah, so let me finish up by saying I was going to probably talk about more about pain and how pain is mediated on May 7th, so that's a future attraction. And I want to finish up with the last slide from today. This is Happy Holidays from the UWMC inpatient neurology team. So, ready to take questions.
Is there any information about the patients who've had a genetic cause of insensitivity to pain, who've been studied fairly extensively clinically? Is there any?
Yeah, so we're looking at the patients.
They itch or don't they?
No, I don't think they looked at. So there's these patients who have a mutation in the TRK receptors, and they're really, I think they're Ashkenazi Jews on the island of Manhattan, and they are ones who just have self-mutilation. And I don't know, I haven't read anywhere whether they cause itching. So or they have decrease in itching.
We had a family here in August once, and a relative described, and there were 2 or 3 papers. I have to look back to see
Are they TRK
what they said about itch, because I can't remember which one of the genetic mutations this family has, but they could not feel pain, these two brothers, and they had Charcot joints. They were always injuring themselves, and they did pathology on them, and they had absence of Lissauer's tracts bilaterally. But what I don't know is
They had
the itch
aging.
question, because I never thought of that.
Yeah, Dr. Krass?
The brachioradial syndrome, you said it's most of the time bilateral, right? So that suggests that it's not a root process or other mechanical problem. Sounds like a central cord process. And you said that these fibers are crossing centrally. Just wonder if anything has been found there.
Yeah. I think in the cases that Mayo was presenting, I don't think when they looked at the images, they really didn't find any much changes to the area around the central canal and the crossing fibers. A lot of the cord was not affected.
And then the second question, you put up a lot of different drugs, but what was interesting was about that bupropion, the mu agonist or mu antagonist kappa agonist drug, or did I get that right? Is that the way it is? And you didn't have that up there, and yet that seems like a logical treatment option.
Yeah, I think that's such a new drug that people really haven't looked at that.
You do have to have special permission to use it, and you have to take a course and a bunch of other things. So I don't know, it's only pain docs who have that ability, but it's an interesting drug. And if you tried the amitriptyline ketamine mixtures, you can get those compounded around town.
I haven't tried it. Have you?
Well, I've tried it for I've just tried it over the last 6 months for some neuropathies and had a little bit of success, actually. With it, you can get it compounded in Ballard. But it was interesting to see that up there in your list.
Yeah. All right.
So, Leo, going back to the pathophysiology, a lot of these people had complete resolution during follow-up. If you've got a mechanical root lesion, it doesn't resolve. It just simply gets worse.
Right.
So that bothers me. That makes me think, why not entertain the possibility that some of these people have a neurotrophic viral syndrome, like idiopathic brachioplexitis, but not motor, more of an itch or it could be something that's strictly sensory in its proclivities.
I think that's totally a really reasonable hypothesis, especially since when you look at it by EMGs, a lot of these don't have any changes that you would expect of a radiculopathy. But I think that a lot of these patients, at least in the Mayo experience, 22 out of 75, only 22 out of 75 had some sort of complete resolution or improvement. So it's really small.
Do they have back pain or neck pain? Which is almost inevitable if you have a sensory root syndrome.
Right. I think a lot of them didn't. So
Didn't?
Yeah, it did not.
Yeah. So that would make me...
Didn't it with bilateral, but 80 to 90% of people with root injury get better all on their own without anything done.
Yeah, they have episodic, they do have some ups and downs. There's no question about that.
Have you guys seen brachioradial pruritus?
I don't know.
I've missed it if I have.
I would never make such a diagnosis. What was the ingredient of itching powder that we would buy as kids to put on our friends?
Cowhage, probably.
That's right.
Huh? Do you know?
I don't know. No.
We weren't that neat.
Tincture of poison ivy.
Sumac.
Hey, what is poison ivy?
I think it releases histamine in that food, I guess. You can use it. You can use an antihistamine to treat it. All right.
Thank you.
Thanks, everybody.
Great.